I would prefer, I think we'll get more out of it, frankly, if I can make the case for you at least on why you want to push at your hospital for these two modalities. How many of you have a Heliox at your places? Not very many. And how many of you have nitrous oxide? Probably none. One? Two. Now the Australian, I'm very glad you're here, Doctor, because we're going to need your input on this, because the Australians basically are way, way, way ahead of us on this. They're not so kind of weird about, oh geez, you know, the anesthesiology department's going to go nuts if you do this stuff. And there's some compelling information in here that I think that would suggest we need to be more aggressive about this. As a matter of fact, I just saw a educational program for nurses to be able to give nitrous oxide in the hospital, nurse administered nitrous oxide kind of thing. So first let's do the Heliox one. You know, it comes in 60-40, 70-30, 80-20. And obviously the more 60-40 helium oxygen, and so if a patient needs to have a lot of supplemental oxygen, you wind up giving less helium. So ideally you'd like to give as little, you'd like to do the 20, 80-20 if you could, 70-30, and by the time you get to 60-40, you're not giving as much helium as you could. But a couple of common things in respiratory problems is, number one, ventilation. You have to pull the gas in. And pulling the gas in could be a problem in the trachea. It could be RSV, it could be bronchiolitis, it could be a foreign body, it could be angioedema. Anything that blocks up the trachea, your diaphragms are sucking down, trying to pull in air, having a difficult time to do this. That's number one. Number two, what about the things like asthma, COPD, CHF? All of these things basically have a ventilation issue in terms of can't pull it in air. Asthma, all the airways are constricted. You have some issues with regards to heavy, wet lungs. Like in CHF, the lungs are now weighing a lot, so it takes a lot of work to open these things up. Not only that, there's this issue of diffusion of oxygen through all of this interstitial fluid now. All of these kinds of things seem to have pneumonia. Basically, you got some issues regarding excess work of breathing. You start to see them kind of intercostal retracting kind of thing. So there is this commonality here of ventilation problems and in certain cases diffusion problems, both of which can be addressed by the use of helium, because helium decreases the work of ventilation. ER patients in particular, but a lot of hospital patients in general, often get supplemental oxygen. You see every ambulance patient coming in, no matter what the heck's wrong with them, they got oxygen running on them. It's like you can't hurt, 20% is okay, 30% has got to be better kind of thing. And the fact of the matter is that I think it's helpful to remember that the vast majority of the transfer of oxygen to the cell level is done by the oxygen that is carried by hemoglobin. Only about 5% of the oxygen transfer relates to the stuff that is dissolved in the liquid phase of blood. Yet that's the phase that we measure. You do blood gases, you're measuring the dissolved oxygen in blood, you're measuring the dissolved CO2 in blood, but that only infers really what's happening with the 95% of the fact is that the hemoglobin, and they're making an extrapolation to O2 saturation. O2 saturation is extrapolated from what is the dissolved oxygen in the blood, which is measured. But the fact is that you could have all of these problems associated with you don't have enough hemoglobin, or your hemoglobin is not able to carry oxygen very well, like in methemoglobinemia, those kinds of things. So we give all of this supplemental oxygen, but where is that going? We're trying to dissolve it in the blood, but that's not really where the action's taking place. One of the issues with regards to this diffusion business is nitrogen is a lot heavier than helium. And the papers point out that CO2 diffuses 4 to 5 times faster through Heliox than it does through nitrogen. So in these issues where there is a lot of interstitial edema, like in pulmonary edema, the idea of transferring the CO2 through this increased interface between capillaries and alveoli is an issue. If we could have something that diffuses faster, better in that situation, like helium versus nitrogen, that's kind of a cool thing. And then we have this issue of ventilation. This stuff flows easier, more laminar flow versus turbulent flow associated with. So that's all the theoretical reasons to do this. It's not any more expensive than an H tank, one of the sizes that is 30% more than oxygen. So it's not an economic issue whatsoever. 30%. There's hundreds of hours of ventilation in that tank. So the main issue here is a lack of familiarity and a lack of compelling data that says, well, this is a great thing to do. But the fact of the matter is there's a large literature, generally relatively small about this. And what we're talking about is Heliox buys time. It's not going to resolve any kind of edema that you have. It's not going to make bronchiolitis or croup any better. But the fact of the matter is as soon as they start breathing that stuff, within a short period of time, half hour, you notice that their work of breathing is obviously improved because they're breathing this lighter mixture. So it buys time so that the steroids that you're giving or the other stuff that you're giving, the adrenergics, et cetera, so it's doing its job and it's buying you some time. So the first papers talk about upper airway obstruction, and that's classically where this stuff is supposedly routinely kind of beneficial. So the first paper talks about tracheal angioedema. You know, you see these people who've gotten these ACE inhibitors, the tongue swollen up kind of thing. It's kind of, oh my goodness, it's kind of nasty. This would be an opportunity to use this stuff. Second paper, 5 patients, 3 Croupers, 1 supraglottitis, 1 laryngeal polyp with edema. The third paper, 29 Croupers. They compared in this paper racemic epinephrine, Heliox, and the Heliox was at least as good as racemic epinephrine in terms of facilitating the transfer of the ventilation, which is an issue in these cases. So that's 29 Croupers. The fourth patient, there's only 4 patients, post-intubation stridor, RSV-associated tracheal obstruction. Now, RSV supposedly doesn't respond to anything. You know, they've looked at the studies on RSV and steroids and epinephrine. And the fact of the matter is that the literature says neither of those work, despite the fact that we're going to still give them because we got nothing else to give them that. And then the other paper, and the other patient there of the 4, severe asthma. So these are a series of case studies, certainly not compelling. But the question is always in therapy, am I going to hurt somebody with this or am I not? Is there some danger using Heliox? And the answer is there's no danger in using Heliox as long as you're giving them enough oxygen. So that being the case, there would be a low threshold to incorporate this into practice because there doesn't seem to be any downside, only an upside. Now we'll get into some of the more interesting papers. So paper number 5, 38 ICU patients with RSV bronchiolitis between the ages of 1 month and 2 years. 2 years is kind of old for bronchiolitis, but in any case, there's 38 cases. They compared nebulized epi and supportive care versus the same treatment with Heliox. With the Heliox treated group, they were in the ICU 2 days less, 5.4 versus 3.5. 5.4, 3, 2 days less. Clinical scores were better within 1 hour with Heliox. Clinical scores, out of a 10 being the worst, went from 5.5 with the non-Heliox group to 3.5. So an absolute difference of 2. But the nice thing about it is it happens quickly because basically as soon as you're flushing out the nitrogen oxygen and replacing it with helium oxygen, you made a difference. The next papers talk about COPD. Number 6 says there was some statistically significant benefit, but often statistically significant benefit and clinically significant benefit are different. Heliox, number 7, decreased the work of breathing, improved gas exchange, and significantly decreased the work of breathing. The clinical effect, however, was small. 8, substantial decrease in air trapping in mechanically ventilated COPD patients. So these are the worst of the worst. Like as an example, the air trapping, however they measured it, 215 versus 99. Decrease in intrinsic PEEP from 9 centimeters of water to 5 centimeters of water. And decrease in peak airway pressures from 30 centimeters to 25 centimeters. All good things. So you don't want to blow out these lungs, high pressure ventilation in intubated COPDers. So that's good. The rest of the papers, a bunch of these papers are on asthma. Papers number 9 to 22 are all on asthma. And the asthma papers fall into 2 categories. One of them is where they are using Heliox to nebulize your adrenergic. And the other paper's talking about just tidal breathing. Between these nebulizations, they're just going to breathe this Heliox stuff. Number 9 is an impressive paper. It improved outcomes in kids with moderate to severe asthma. And here's one of the key things in these papers. If you look at the use of the outcomes of adjunctive therapy, and you'd have to consider this to be adjunctive therapy in the setting of asthma. We're going to throw in, let's use some Heliox here. To be able to see the difference between non-Heliox and Heliox, it's very difficult to do that in cases that are mild, because in cases that are mild, the standard treatment works so well and so quickly improves them that it's hard to show that this makes any difference. In patients that are really bad, their FEV1s are less than 30% of predicted kind of thing. In that subset, those are the patients where you might see some advantage as, for an example, of using IV magnesium. Those are the patients where you might see some example of using Heliox, because they are so bad, the standard medications don't seem to be doing a heck of a lot. This is the opportunity to see the potential value of adjunctive therapies. So these patients had moderate to severe asthma. They reduced what they call their pulmonary index. It was a score at, which was around 10 at baseline. It's a score over 8 is considered to be severe asthma. So they started out around 10. They down with a standard therapy, they get down to 6.7. With the Heliox, they get down to 3.3. 2/3 were discharged on the Heliox. 1/3 were discharged without the Heliox therapy. So you're buying time. You're letting these other drugs kick in. You're using your steroids, etc. So this was a clinically apparent difference within 2 hours of the onset of this therapy. Number 10, compared nebulization with oxygen or versus Heliox. 3 treatments with albuterol given Heliox-driven versus oxygen-driven. More rapid and greater improvement. The peak flow, 70% improvement versus a 40% improvement in peak flow. The worst patients had the relatively best outcomes. That's the key. The worst patients had the relatively best outcomes. And that's an important point in general. Number 11 is an interesting paper. This is again where they're using Heliox to nebulize their adrenergic. And in this study, there was severe asthma, 30% of predicted value, number 11. That is nasty. That is nasty. Some of these papers are using people between 40 and 60% FEV1 predicted. Those are cases are mild to moderate. 60% is certainly moderate. But in any case, let's see what happened with the median change in FEV1 after the first treatment. They compared Heliox administered adrenergics, non-Heliox administered adrenergics. So the FEV1 improved by 32% with Heliox after the first treatment, by 15% with oxygen. After the second treatment, the FEV1 had improved by 52% versus 23%. And after the third treatment, FEV1 had improved by 65% versus 27%. A marked difference. Now, in this study, there was no difference in the admission rate, but because you have to remember, Heliox is buying time, not fundamentally treating the underlying problem. Now, not all of the papers are positive, and I think it's one of the reasons that this has not become standard therapy, because there is some controversy regarding the magnitude of the improvement that is going to be associated with it. So 12 and 13 are no advantage to Heliox papers. Number 12, look at it. Oh, patients had mild to moderate asthma. Well, you're not going to see a big difference in those cases. They used 70-30 Heliox to drive the nebulizers. And number 13, the patients were not as sick. These are people who had FEV1s of 40% or greater of predicted, and they used continuous. So not all the papers are positive. I think one of the Achilles heels in at least number 12 is moderate cases, not going to see very much. And 14 suggests that to nebulize adrenergic helium, you ought to turn up the flow rate a little bit. 15 to 20 are all focused on the use of Heliox between nebulizations. So this is tidal breathing now. So if you're not going to give them their continuous adrenergics, you're going to give them an adrenergic, you're going to wait 15 minutes, give them another adrenergic. This is the tidal breathing helium papers. Read the conclusions of these papers, 15 through 20. These are positive papers. Now, there are some negatives. 21 and 22 are negatives. 21 is a systematic review of 7 randomized controlled trials or non-randomized trials, and they conclude the evidence doesn't support its value. Well, we have a conflict here. So I think when there's a conflict in the literature and you're dealing with something, your back is to the wall. These are nasty asthmatics. You do not want to intubate them. You certainly don't want to go to positive pressure if you can avoid it. Why not use this stuff? What, is it going to hurt you? No, it's not going to hurt you. It's not going to hurt you. So 21 is not very positive, and 22 said we didn't find an increase in FEV1. That was only 18 patients. Well, I got some papers where they did find an improvement in FEV1. The FE1s in 22 were between 20 and 60% of predicted. Well, 20% of predicted is terrible. 60% of predicted is mild. They excluded patients treated with bronchodilators within 1 hour. I don't know why that would occur. So my conclusion is your respiratory therapist will think that this is cool. Let's get some of this Heliox, keep the tank in the emergency department. If it's not there, it'll never get used. And get some familiarity using it with Croupers. They can breathe this stuff. Anybody who's got any kind of wheezing thing, narrowed airways, gas flow is an issue, ventilation is an issue, work of breathing is an issue, intercostal retractions is present, give it a whack. It won't hurt them, and then when you're back to the wall, you may feel comfortable. Let's give them some Heliox. I can tell you another advantage of Heliox is that we used this in a woman who came into our emergency department who had intermittent asthma, and she was really actually pretty bad, and we had the Heliox bottle there. We put the Heliox bottle, and apparently she had been intubated once before. None of them like that kind of thing, that's for sure. So we put the Heliox on her, and basically she turned around. Whether she would have turned around with it or without it, God knows. But the fact of the matter is that she thought this was an incredible emergency department. You're the only one who's got this stuff. I want to go on to your foundation. I want to raise money for your hospital. So there was a really very, very positive spin-off. This lady thinks our hospital is fantastic because we were the only one that had this stuff kind of thing. And now she's been one of the biggest advocates for the hospital, bringing in all of these people who are making donations. So even if it doesn't work, get that bottle out there kind of thing. You're going to find yourself a donor pretty soon. All right, this is the ones I'm going to need the help of a doctor from Australia here. This is the next paper is about nitrous. You go to the dentist, some of these dentists use nitrous oxide. Do they basically have an anesthesiologist in attendance when they're using this stuff? No, they don't have any anesthesiologist there. They're cleaning your teeth. They're doing this and that kind of thing. And you're pulling out your wisdom teeth and all this other stuff and with nitrous oxide and little this or that. And yet for us now, I asked our head to have anesthesiology after reading some of these papers. I said, listen, give us this stuff. Give us the, we used to have it in the 70s when I got out of my residency. We had all of this, they had Nitronox, this 50-50. It was like, they had 2 versions. One of them was one bottle that was blue and green, oxygen and nitrous, 50-50. Half the bottle was green and half the bottle was blue. And then they had these other ones, which was a machine, and they had 2 bottles, nitrous and oxygen, with a valve that was fixed at 50-50. So that was the Nitronox kind of stuff. And we use this all the time. Now the issue is, well, was 50% strong enough to get the effect that you wanted? We'll see some papers here that suggest that it is. But the fact of the matter is that those who know basically said, yeah, let's up the ante on this. You can go to 70% for a short period of time. They're still getting 30% oxygen, which is more than room air, so that's cool. So this first paper, I thought it was a great paper, number 23, nitrous oxide for ED facial laceration repairs by a plastic surgeon in Israel. 60 kids, mean age 4. They gave them 50-50 nitrous oxide versus standard care, whatever that was. Average duration of the suturing job was 12 minutes. Recovery time, 1 to 2 minutes. Pain with lidocaine infiltration. The kid, visual analog, watching the kid. 2, pain with nitrous, there's 2. Pain with injecting the lidocaine without nitrous was 9.7. Huge difference. None of the kids needed to be restrained who were given nitrous versus the kids who weren't. There was no IV line necessary. They had a rapid onset, rapid recovery, cost pennies. And the only problem in this study, which is a recurring problem, and I have to ask our colleague here. 8 out of the 45 kids vomited. Now that's kind of high. 8 of 45 vomited. And you're going to see that there's, now that's 8 of 45, what is that, 1 in 6, about 16% vomiting. That is high. 24 is another facial suturing study. They compared oral midazolam plus standard care plus versus midazolam and nitrous. 204 kids, this big study. They had these behavioral scores in terms of how the kids were tolerating their suturing up. Better with nitrous oxide. What about satisfaction of the suturer, the doctor? It was, nitrous was just as good as nitrous plus midazolam. But 6 kids vomited. 6 kids out of, and I wasn't able to determine whether this was 6 out of 50 or 6 out of 100. So let's take the worst case scenario and say it was 6 out of 50. That's a 12% incidence of vomiting, 16% in the other, 12% in here. Now those are on the high side. 25 is a systematic review of the sedation in kids for fractures. 2 studies found it to be as effective as meperidine and promethazine or a beer block for fractures. 26, it addresses this issue of pre-procedural fasting. Pre-procedural fasting. That always comes up. It's an Australian study, 220 kids between the ages of 14 months and 17 years old. Huge. And they gave them 50, 60, or 70% nitrous in the ED. 15 vomited. That's 7%. That's a better number, 7%. Fasting was not related to emesis. There was no serious adverse effects. This is a pediatric emergency care published in November of 2005. But the question is, why stop at 50%? 27 is another Australian paper because they have this stuff, and then the other Australian doctors who have come to this course have told us about it, and they use this stuff. This is 224 kids over the age of 1. And this study, and it was given by nurses, there was one major adverse event. That's just 224 kids. What was that horrible event? Transient tachypnea in a patient with recent bronchiolitis. Transient tachypnea. Now, that can't be considered a horrible event. 8.5% emesis. Again, better number, 7%, 8.5% better. 28, a French study, 1,000 kids, 31 centers, 50-50 nitrous. They did it lumbar punctures, they did it in bone marrow aspirations and laceration repairs. The visual analog scale of 647 of those 1,000 kids who were over the ages of 6 who could basically talk to you was 9 out of 100. 9 out of 100. Substantial relief of no serious side effects in that study of 1,019 kids. 29 showed that Entonox 50-50 was better than intra-articular lidocaine for shoulder reductions. And my favorite paper is number 30. This is venous cannulation in 50 kids. They gave them 70% nitrous for 2 minutes. 2 minutes. They compared nitrous with EMLA. EMLA doesn't work. 80% of the kids getting nitrous had a visual analog scale of 0. 80% getting nitrous at a visual analog scale of 0. Why? Because they had no apparent recollection of the IV even being started. The mean visual analog scale in the study was 4.4 with Heliox, Entonox, versus 22 with EMLA cream. So I need some testimonials now.
I was just wondering how this worked for those hemorrhoids. You know, those are the most miserable things you can anesthetize them.
No, and it's hard to anesthetize abscesses, all of that, those kinds of things. So what is the story here? Why can't we use this stuff? Doctor?
I'd just like to know about the scavenging of nitrous oxide.
Right, that has to, you know, when you talk to the Australians, they basically hook up the wall suction kind of thing and put it around the person. They don't make a big deal of it. There was some issue about just venting this stuff into the department and the nurses having kids with 7 fingers, you know. You know, there's going to be some downside. But, doctor, can you tell us about what you know about this stuff in Australia where they've been using it for a long time?